I know we have a number of people here today from civil society, and I know they're always curious, and the topic always comes up of how can organizations like Integrate Health, which works in Togo and Cote d'Ivoire and across West Africa, how can civil society really be a great partner in achieving these health gains, not just in a county where you're delivering direct service, which is critical, but also making that go national?
Thanks, Madeline. So it's kind of a big responsibility to represent the NGO voice when I'm in the room that has the most effective group of NGOs that you will find during this whole entire UNGA week. So I take that responsibility seriously. But at Integrate Health, we think about our role working with government as what we call a learning lab. So we gave it this name to really try to underscore what this means, but I'll break it down for you, and it's really three very simple things. So the first is exactly what you just said and what we've heard from our ministry colleagues, partnership. So what I mean by partnership is real relationships. So we do this at Integrate Health by our colleagues form relationships with their counterparts in the ministry at all levels. At the district level, at the regional level, at the national level. We as NGOs, first we have to listen, we have to bring humility, and then we can create a relationship that's anchored in trust. And what this means is that when our partners need us, when the ministry needs us, they pick up the phone and call us. So that's the first piece, real relationships, real partnership. Second piece is risk. NGOs are uniquely positioned to take risks. We have the ability to leverage philanthropic funding to try things that our government partners and our local community partners cannot. And that is a unique privilege. So at Integrate Health, we've used that to test a fully integrated model to strengthen the primary health care system that leveraged professional community health workers integrated with improved facility-based care. And when we did that, we observed a 30% reduction in the under 5 mortality rate at a cost of $10 per capita. Again, underscoring the evidence that Madeline, you shared, this is cost effective and it works. So that brings me to the third piece, which is learning. This is where we bring together these real, genuine partnerships and the ability to take risk in order to generate evidence, in order to learn. But the important piece here is that we're not just learning about the things that we care about or the things that maybe our funders are asking us about. We have to learn about what our government partners are asking about. What are the questions that they have? What are the data points and the information that they need to navigate these hard decisions to understand how to make trade-offs in resource allocation? So I want to share an example of how we did this. I'm going to bring us, we've now gone from Southern Africa to East Africa. I'm going to bring us to Guinea in West Africa. And so now we can't say, oh, this only works in this part of the continent. And we've done this work both in Togo and in Guinea. And we gave this approach a real pithy title so everybody can remember it. We call it Chunk It, Cost It, Test It. And we've written about the work we've done in Togo to help scale maternal health reform in Stanford Social Innovation Review. So if anyone's curious, I encourage you to read that piece. But today I want to talk about the work we're doing now, live in real time, with the government of Guinea to decentralize financing for community health worker salaries. And so Guinea has, on paper, a very strong professional community health worker policy that both includes payment for CHWs and permits that payment to be administered by local communes. So this is really important because it empowers decentralized government to take ownership of this very important element of the community health worker program. But the government was having a hard time having these payments actually happen. So the policies there, the environment has been created. As Dr. Aluga said, we have the political will. And so the government called us and said, can you help us make this happen? And with generous support from the Global Funds Project Birch, we started working with 10 communes, so 10 decentralized governance units in Guinea, to look at this approach. So chunk it first, pull out the community health worker salary piece, cost it, figure out how much they cost and exactly what needs to be written into those local government budgets. And then test it. We started working together to test different approaches, create dialogue, really understand what the challenges were. And through this approach, I'm thrilled to share that 7 of the 10 communes that we've been working with are now supporting community health worker salaries from their local budgets. Thank you.